I'm Ann Curtis. I'm from the University at Buffalo in Buffalo, New York, and I gave a presentation today on is cardiac resynchronization therapy proarrhythmic? And what we mean by proarrhythmia is actually aggravating arrhythmias such as ventricular tachycardia and fibrillation. We know that CRT helps patients who have advanced heart failure. It helps reduce symptoms. It helps in terms of remodeling the ventricle and making it smaller. It helps prevent hospitalizations, and it also reduces mortality rates. But there have been some reports that CRT can actually be proarrhythmic. And so when we look into that, what some studies have found is that the reason that you might aggravate arrhythmias with CRT is the fact that the leads are placed epicardially, because they go in through the coronary sinus, they're placed epicardially on the left ventricle. And that placement of the lead on the outside of the heart seems to promote having the QT interval be longer, and because of that, it actually can cause more dispersion of repolarization in the heart, and with that, you do get ventricular arrhythmias. So there are some isolated case reports showing that to be the case. On the other hand, there are other studies that have shown that with CRT versus placebo or standard medical therapy, that patients actually had fewer ventricular arrhythmias. So we have to ask ourselves, why is there that difference? What is the real answer here? And if you look at further studies, including MADE-IT-CRT, which I talked about, and MADE-IT-CRT was a study looking at cardiac resynchronization therapy in patients who had less severe heart failure. And what they did was they looked at CRT versus ICD therapy alone, meaning no CRT, and then looked at patients who were responders to the therapy versus those who didn't respond. And the responders were defined by a marked improvement in LV remodeling. And if you looked at the patients who were the responders to therapy, they had many fewer ventricular arrhythmias compared to patients who got ICD therapy alone, whereas patients who were non-responders, so in other words, they got the lead, they got the therapy, but they didn't improve, they actually had more arrhythmias than the patients who had ICD therapy. So what I believe we can conclude from all this is that if a patient gets cardiac resynchronization therapy and responds, then they will actually have a better outcome in terms of getting fewer ventricular arrhythmias. Whereas if patients don't respond, it will be worse. So to me, the take-home message is make sure you select the patient appropriately and make sure that you get the lead in the best location so that the patient can respond to therapy and then have the added benefit of fewer ventricular arrhythmias in addition to the other outcomes that we know you can get from cardiac resynchronization therapy.